Good afternoon, good evening, ladies and gentlemen. I would like to personally welcome you to our Taewoong Medical USA clinical-based webinar. My name is Daniel Beck, and I'm the marketing manager for Taewoong Medical USA. We have a great turnout today, both in the US and international audiences. Our subject today is on the EUS guided therapies in pancreatic neoplasms. Our speaker today is Dr. Tamas A. Gonda, Associate Professor of Medicine at New York University School of Medicine, Director of Advanced Endoscopy, Director of Pancreatic Disease Programs. His research area is preclinical transitional investigation in new therapeutic and chemo prevention targets in pancreatic and gastric malignancies. Most recently, his focus has been on potential of epigenetic priming to response to immunotherapy in pancreatic cancer. His clinical expertise is in the pancreatic biliary disease as an interventional gastroenterologist. You can expect this webinar to last around 1 hour and 15 minutes, including Q&A sessions. There will be more information on USRA RFA technology in the middle of the link, and there are polling questions throughout the webinar that will be available to you to answer as you wish to help us understand more about your needs. Now, I would like to welcome Dr. Tamas A. Gonda to begin his presentation.
Thank you. Thanks very much, Daniel, and good afternoon, good evening, or I guess good morning, everyone. Thank you very much for joining. We're going to be talking about EUS-guided therapies for pancreatic neoplasms. I'm going to start with a brief introduction of some of the conditions that these therapies are evolving to be used in. We'll talk very briefly about pancreatic cystic neoplasms, neuroendocrine tumors, and pancreatic adenocarcinoma, and how we can what would be the rationale for using any of these EUS-guided therapies in these conditions. And then we will talk about the specific EUS-guided therapeutic approaches with a focus on ablative therapies, such as chemical ablation, radiofrequency ablation, and some additional ablative technologies, such as irreversible electroporation. And towards the end, just briefly, we'll touch on injectable therapies, such as injectable chemotherapy and immunotherapy. So a very brief introduction of these three groups of neoplasms in the pancreas. This is obviously a talk not focused on these entities specifically, but just to understand where ablative technologies may have, or ablative treatment methods may have a role. So pancreatic cystic neoplasms are one of the sort of most common entities that are identified in the pancreas. And the majority of the ones that we sort of think about as quote-unquote treatment targets for ablative technologies would be IPMNs and mucinous cystic neoplasms. In some recent work that we've actually done on very large clinical databases, one can expect to identify these cystic lesions in 2 to 3% of the general population over the age of 65. And although overall these lesions are rarely malignant at diagnosis, they carry a somewhat variable but significant risk of progressing to invasive carcinoma. There have been a tremendous amount of work, and again, this is not the focus today, of trying to identify what the risk of cancer is associated with these cystic lesions, and they break down typically into these three categories: cystic lesions with high-risk stigmata, cystic lesions with worrisome features, and cystic lesions that are low risk. And essentially, the high-risk lesions that carry the so-called high-risk stigmata as defined by imaging and clinical features carry a risk upwards of 20% of harboring carcinomas. So we generally treat these kind of in the same bucket as pancreatic cancer, with a clear intent of curing these individuals. Those that have a worrisome feature have a variable risk that, depending on where you look in the literature, may be a cancer risk somewhere between 0 and 5%, and the low-risk cysts typically carry a truly low risk of less than 1% of carcinoma at time of diagnosis. However, several of these patients will progress to develop higher risk findings during surveillance. And if they do, the risk of identifying cancer at that point can be, again, as high as 2 to 5%, like with the worrisome features. At the moment, surgical resection is generally considered the only therapeutic approach for these cystic neoplasms. And as probably all of you know, pancreatic surgery carries a significant morbidity and even a mortality rate with it. although it is important to note that recurrence of these lesions is extremely rare in a curative intent surgery. So this is a very successful treatment, not without its downsides in terms of morbidity and mortality. So when considering alternatives to curative resection in pancreatic cystic neoplasms, I think one can think of high-risk and worrisome feature lesions, so the real higher-risk entities, as ones where an ablative technology would need to show a very high degree of efficacy of complete ablation. And the low-risk lesions, really the focus or the main criteria is to provide an incredibly safe ablation method. I kind of think of this category as a little bit analogous to Barrett's esophagus ablation, where the efficacy may be in the 70, 80, 90% range, but you need to have a technology or a method that has a very, very high risk, very, very good safety profile. What about pancreatic neuroendocrine tumors? So this is an entity that, at least in some parts of the world, we're clearly seeing a significant rise in incidence. In some ways, the incidence of neuroendocrine tumors diagnosed really is outpacing the incidence of almost all other malignant neoplasms. And the majority of the neuroendocrine tumors that are diagnosed are localized disease. One of the most common sites of this being pancreatic neuroendocrine tumors. So this is clearly an entity that we're seeing a lot more of. Not dwelling into, again, the sort of true natural history and clinical sort of workup of these neuroendocrine tumors, they are generally broken down briefly into those that are non-functional neuroendocrine tumors and those that are functional neuroendocrine tumors. And a little bit similar to the cyst sort of conversation, smaller neuroendocrine tumors are an area that is sort of actively, to some extent, debated, but is potentially considered to be a relatively low-risk malignancy where observation or non-surgical treatments are considered. And then, of course, functional neuroendocrine tumors are sort of on the other end of the spectrum, where really the functional or the hormone secretion is what the sort of focus of treatment is. And sort of analogous to this, these are some of the areas where ablative technologies have a real sort of rationale for using. So again, in the sort of lower risk end, lower risk lesion end, safe technologies that can with sufficient efficacy ablate neuroendocrine tumors may have a very significant role. In the functional neuroendocrine tumors, especially in localized disease, especially in patients with very small lesions where the metastatic potential is relatively low, there's a significant role for ablative technologies. And even in this category, even in metastatic disease, sometimes for control of pancreatic disease or local disease, there may be a role for ablative technologies. And then finally, what about pancreatic adenocarcinoma? So as I think, again, most of us know, the pancreatic cancer is becoming sort of potentially one of the most lethal, if not the most lethal, cancers among solid malignancies. There are many reasons for this. I like to show this slide because I think it sort of tells a little bit the story and the evolution of how some of the other truly deadly cancers have changed. Their treatments have changed over the years, and how this has not happened in pancreatic cancer. So very quickly, this just shows you that a few years ago, pancreatic cancer and, for example, non-small cell lung cancer chemotherapy trials looked quite similar with, aggressive treatment regimens here showing relatively modest survival benefits. With the advent for some of these cancers, such as non-small cell lung cancer, of immunotherapy, these survival curves have truly shifted and are showing us very significantly different shape. Unfortunately, this has not happened in pancreatic cancer. There are many reasons, and this is just a tiny bit of biology which will become relevant, but there are many reasons why this may be in pancreatic cancer, and certainly a big part of that is the very complex mutational landscape of pancreatic cancers and pancreatic cancer cells. But an increasingly well-recognized area that is sort of a focus of treatment has also been the recognition that outside of the cancer cells, the microenvironment, what surrounds cancer cells in the tissue, is also highly unfavorable for pancreatic cancer treatment. It's surrounded typically by this dense fibrous stroma. There's hardly any immune cells or immune response, anti-tumor immune response in the pancreatic parenchyma. And essentially, this environment creates a situation that is unfavorable for immunotherapy, but is also very difficult to get any kind of chemotherapies in there. Some studies have shown these collapsed blood vessels and a generally avascular tumor, which again hinders the ability of chemotherapy to reach the pancreatic cancers. So an important area that I think ablative technology, at least for now, to some extent hypothetically, although there's some evidence now that this may not be so hypothetical, that may be a significant advantage or an opportunity, is the ability to sort of increase the immune response to pancreatic cancer. And clearly, what has made this a reasonable target and a feasible opportunity to increase the immune response in pancreatic cancer has been the discovery and introduction of checkpoint inhibitors, which essentially enable immune responses to be used against cancers. But ablative technologies, whether it is oncolytic viruses or ablation-induced tumor necrosis, have significant advantages in potentially increasing cancer cell antigen exposure, recruiting effector tumor immune cells, and cytokine expressions, which are in essence a prerequisite for the effector T cells to appear in the tumor, and therefore to unleash the benefit of checkpoint inhibitors. So to summarize, in pancreatic cancer, the rationale for using or to potentially turning to ablative technologies is in part to potentially offer an alternative to local control, an alternative potentially to surgery to local control, and this would be the most exciting way to use ablative technology. Another way to use ablative technology is to kind of use it as a way to overcome the stromal barrier that is formed in pancreatic cancer. And here, especially directly delivered therapies have a significant advantage. And then the third is this idea that really these technologies can increase the immunogenicity of cancer. And again, this can be done either by ablative technologies, ablative methods, or by various injectional viral vectors. So why is EUS sort of in the center of this? Well, I think hopefully for this audience, this is fairly clear. It is clearly the most the safest and the most optimal way to image the pancreas, to access pancreatic tumors, and it also is the procedure with the lowest risk of tumor seeding during the intervention. So what are some of the EUS-guided therapies that we will talk about? Again, we will start with ablation. We'll talk about alcohol because this is sort of the one where, which is in some ways the oldest and the one where there's possibly the most experience. We'll touch on some of the other ablative technologies with greater emphasis, in part because there's really more data. So radiofrequency ablation is clearly the one that has the most data on it, but I'll briefly touch on some of the other ones that there's clinical data on. And then finally, we'll talk about EUS-guided injection or fine needle injections. So alcohol ablation of solid pancreatic masses is something that has been borrowed from alcohol ablation of other solid lesions over the years, and this is a technically truly not difficult procedure. It's essentially based on a sort of simple calculation of assessing the volume of the tumors, and I always have to return to these formulas and pull out a calculator. But at the end, you sort of estimate the amount of alcohol that is infused. And under EUS guidance, there's a very clear visualization of instilling alcohol. So there have been a number of studies clearly outside of the pancreas, and some of them also reporting on solid pancreatic tumors, which overall have reported reasonable results, certainly reasonable outcomes in terms of response, but a somewhat concerning trend of a significant number of case reports or series showing mild acute pancreatitis associated with alcohol ablation. And this was especially true in an area of pancreatic cystic alcohol ablations, which are done a little bit differently. Essentially, the main difference here is that the cyst fluid is typically aspirated, the alcohol is infused in the cyst, and then after a certain period of time, the alcohol is typically removed from the cyst. But nonetheless, the thought is that there's a significant amount of alcohol leakage that may occur during the procedure, which may explain some of the rate of pancreatitis and abdominal pain associated inflammation in the region. In some studies, this has also described peritonitis, and in a few case series, there have been cases of essentially cholangitis or biliary epithelial biliary irritation resulting from this. So some of the benefits of alcohol ablation have clearly been the significant clinical experience that is borrowed to some extent from other organs and tumors. The fact that it's relatively simple to do and obviously low cost. But the greatest concern here is that with diffusion and leakage, there is a significant direct local caustic effect. And this is especially true for cystic lesions. And then finally, a little bit less so in solid neuroendocrine tumors. In cystic lesions, the other sort of concern has been an efficacy that, if you go back to the previous slide, that is really only in the 30 to 40 to 50% range in terms of cysts resolving after alcohol ablation. So there's a significant efficacy concern here as well. How about non-chemical ablation? So now we get into some of the other ablative methods. So stereotactic body radiation is really only here because sometimes EUS can be used as a way to guide stereotactic body radiation. But really, some of the more non-chemical ablation methods are radiofrequency ablation, which uses thermal energy to essentially cause a coagulative necrosis, cryoablation, which is a somewhat similar mechanism, and irreversible electroporation, which is here because it's an important ablative technology used in the treatment of pancreatic tumors, less so EUS guided at this point, which uses electricity to alter the properties of the cellular membrane and essentially causes apoptosis in situ. So I will just very quickly touch on this. This is a highly effective method that is typically done either by percutaneous route or by, or most frequently by surgical route. And really the idea is to essentially trap the tumors between multiple electrodes and deliver irreversible electroporation, which essentially destroys all of the cells, but does not destroy the cytoskeleton and essentially the structure of blood vessels. So this can be done very effectively adjacent to blood vessels without causing a significant damage or significant destruction. And some of the reports, and again, this is surgical literature, so this is not EUS-guided technology at this point, some of the reports have really shown essentially survival curves or clinical outcomes that in some ways are approximating the in situ surgical resection data. It's still relatively preliminary, but this is very promising as a potential alternative or adjunct to surgical resection. Notably, despite the idea that vascular damage is not often seen, there's a significant complication rate that have been described in some of these studies with this technology. And there have been some efforts. This is truly just early days of converting this technology to an EUS-guided method, but it's clearly not there yet. And one of the issues here is that it typically requires 2 electrodes or at least 2 ports, and that's obviously a barrier for EUS-guided treatment. So again, I mentioned SBRT as a way of ablating tumors, and this is routinely done. And EUS really here has a role of essentially placing fiducials and guiding this therapy, which is a very important modality, and again has shown significant efficacy in some studies comparable to surgical resection outcomes. What about radiofrequency ablation in the pre-EUS guided era or from percutaneous and surgical series? So there have been a number of these series, and again, the efficacy has been reasonable, but notably there have been significant toxicities or adverse events associated with it. So in general, I think the surgical literature and the IR literature has moved truly away from RFA as a technology used in the pancreas. And if you look at some of the parameters here used, one of the reasons for that may be the very high energy RFA that have been used in some of these studies. Nonetheless, this slide sort of summarizes some of the pre-EUS data of ablative technologies and shows that, a lot of these technologies really show promise with, not insignificant number of patients that have been enrolled in trials and median overall survivals that in some of these studies are not too far from the from surgical series for stage 1, 2, 3 pancreatic cancer. So what are the potential benefits now turning to EUS-guided technology, in particular to EUS-guided radiofrequency ablation? So obviously one is a safer and a much less invasive access than either a percutaneous or typically a surgically assisted access. A direct visualization of the treatment area during ablation, and we'll show this in a few minutes, as a way to really understand how the ablation happening sort of during the procedure. And most importantly, perhaps especially comparing to some of the surgical placements, it's really a very precise way to visualize adjacent structures, pancreatic duct and vascular structures, which may be something that had to do with the higher complication rates. And finally, based on these targeted methods, an ability to potentially deliver lower dose and energy with potentially the same efficacy as the surgical methods have done. So there are two currently available EUS-guided methods, and I think it's worthwhile to at least mention the two at the moment commercially, at least in the country where I practice, which is in the United States. Only one of these is available, but the two differing methods are: one is a through-the-needle electrode, which essentially is a very small 1 French electrode that is pushed through a 22 gauge needle, any 22 gauge FNA needle. And the electrode is hooked up to an ERBI standard generator and uses radiofrequency ablation using this method. The other method, which is the one that's available in the US, is essentially using a dedicated 19 gauge needle. So this entire needle is an EUS RFA needle. It uses a dedicated generator, and it has a cooling mechanism, which we will talk about a little bit, which allows a more effective ablation strategy. So this is a much larger, essentially, electrode that is placed in the patient. And as this study has shown, and this is sort of a comparing how radiofrequency ablation of tissues works using these two probes. And as this study has shown, one of the sort of obvious advantages of the EUS, the EUS RA probe, or the needle device that is not a through the needle technology, is that essentially it delivers a significantly larger power in a much shorter period of time, and achieves, if you look here on the right, achieves a sort of greater volume of ablation, but also a similar sort of depth of ablation. So in some ways, this technology allows us to achieve the same sort of ablation in much fewer sessions without the need to reposition the needle, and potentially also, based on the size, allows a greater penetration of the ablative zone. Now, I'm just going to very quickly walk through what are the elements of the system, and then we will talk about some of the clinical results with this and demonstrate a case that uses the technology. So again, there is a dedicated generator that is used for ablation, which shows you essentially the energy that is used, and it also will show you impedance, which is essentially rises as the ablation occurs, and gives a sense of both the effectiveness of the ablation and also the point at which the effectiveness wanes based on tissue destruction and increased impedance in the tissue. It comes with a dedicated pump, which is the part that is required for the cooling mechanism, which essentially cools the needle, and this is sort of a circulating, a water circulation that again increases the efficacy of the ablation. Again, it comes with a dedicated needle, which is not terribly different than a standard FNA needle, with essentially the same mechanism of puncture and usage. And we'll see this in a few minutes during a recorded case. So again, it's a 19 gauge needle. It's a very similar handle to what all of us are used to for EUS FNA. So how do you sort of plan your treatment? So again, the ablation zone is determined by the size of the electrode that is used, and there are 3 different sizes that are available, and this determines how deep the ablation will happen. As this quick graph shows here, what happens during the ablation is that you reach a certain power, at which point the electric current is conducted, and then when the impedance begins to rise, essentially this power, the efficacy wanes, and then at that point the electric power is shut off. So so what happens is that when you set something for a 10-watt 10-second ablation, this is about the size of the lesion that you will be able to ablate, and at around 10 seconds you begin to see a rise in the impedance, at which point either the system shuts off or you have the opportunity to terminate the ablation. If the lesion that you're ablating is larger, the ablation, the corresponding energy that you can use is somewhat greater. The amount of time that you use the ablation is greater, and so is the size of the ablating needle. And then finally, this is the largest size ablating needle, which is a 10 millimeter needle that allows a penetration or an ablative zone of about 14, 15 millimeters, and this requires a slightly larger energy with a slightly larger time frame. But again, as I showed you, since the monitor gives you a reading of the impedance, in addition to these set times, you also will know when sufficient tissue destruction has occurred and the efficacy of ablation wanes, and therefore the ablation should be terminated, which is about somewhere around these time frames. These may be a little bit shorter than in clinical practice are used, but they range somewhere between 10 and 40 seconds. So let's talk about the efficacy of these treatments in some of the published clinical trials, or at this point really more than clinical trials, case series or reports. So probably the greatest amount of literature is for neuroendocrine tumors, and there are 3 studies totaling somewhere around 50 patients that have been reported on. And in general, you know, these are studies that have shown a very high complete response rate. So if you look here, this is the most recent one of these by Marc Barthay's group in France, and this has shown, especially at long-term follow-up, a close to 85% complete resolution. Note this, that this is really only still a handful of patients, but nonetheless a significant response rate. There's one other study that has that had a slightly higher number of patients, which also reported an 84% complete response rate. Also note that the follow-up time, it's interesting that at 6 months, at least by radiographic criteria, there was a significant response, but this number actually grew at 12 months. And this may be something that is sort of a delayed effect of radiofrequency ablation, and sort of a 12 or maybe an 8 to 12 months follow-up is needed to really understand whether the lesions resolve. This image up here demonstrates sort of a standard way to survey these patients. So this is a triple phase contrast CT scan, which shows a nice enhancing small pancreatic body neuroendocrine tumor, which at 2 or 3 months shows essentially a non-enhancing pattern. So you can see it's sort of the similar phase on the CT scan, and there's essentially no enhancement seen. And then as sort of also seen in these in this clinical report, at a later time point, I believe this is at 12 or 15 months follow-up, is when you begin to see the resolution of these tumors. So so again, I think there's truly good response rate in these type of tumors, and they typically seem to be best appreciated at around 8 to 12 months or later. What about in cystic neoplasms? So it is definitely early days in EUS-guided RFA of pancreatic cystic neoplasms. Nonetheless, there are a few reports. This top one is again from Barthé's group, and then the one on the bottom, I believe, is a Korean group. And the efficacy is lower even in the Barthé series. There is significant efficacy if you compare this to the alcohol ablation. These are significantly better numbers. There we were seeing 30 to 50% responses in alcohol ablation of pancreatic cysts, but nonetheless, this is clearly not as high a number as we saw with the neuroendocrine tumors. And in this sort of very early experience from Korea, it's sort of similarly seen that they saw regression of the cysts, but really in only 2 cases did they see the cysts resolve completely. And then finally, efficacy reported in pancreatic adenocarcinomas. So this is also somewhat early days, and this is obviously the most heterogeneous group because many of these patients are receiving concurrent other therapies for pancreatic cancer. Nonetheless, at least the bottom 2 graphs show a relatively larger series of patients, of 10 patients. And if you look here, they tell you the pre-treatment size of the lesion and the post-treatment size, and there is actually a significant reduction in the tumor size. And a little bit similar to the neuroendocrine tumors, the scans show an increased sort of necrosis or lack of enhancement in the tumor after ablation. So I think there is reason to believe that at least local control may be achieved. Whether this is complete response or not, that's very early to tell in pancreatic adenocarcinoma. But of course, one of the important things to consider is what are the adverse events. So in this table, I put together the sort of reported adverse events from some of these trials that are quoted for sort of quote unquote efficacy, and it's broken down a little bit by the type of lesions that were ablated. So overall, in the majority of these cases, really majority of these reports, the most significant side effects have been mild abdominal pain, often associated with, at best, mild chemical pancreatitis. Notably, in the Barthé paper, there were 2 patients who developed infected necroses in the neuroendocrine group, and 1 patient who developed it in the cyst group. And in this article, they make a mention of these particular cases, and that these neuroendocrine tumors were also cystic neuroendocrine or cystically degenerated neuroendocrine tumors, and that what they have found is that in these cases, the endoscopist performed the ablation without a prior cyst fluid ablation. I mean, a cyst fluid aspiration, and I think they adjusted their protocol. Although within these relatively small overall ends, they adjusted their protocol, and when they went to perform the ablations after a near complete cyst fluid aspiration, in that part of the study, they did not see further side effects. So I think there is some belief that the overall adverse events with this technology have been quite low, with very rare or not very rare, but relatively rare mild post-procedural abdominal pain, and that perhaps the cystic lesions are slightly different in that they require a cyst fluid aspiration prior to ablation. And then finally, what to do after cyst fluid? EUS guided RFA. How do we sort of assess tumors? So I think it's relatively clear that, especially for the neuroendocrine tumors and for solid malignancies, all solid malignancies, a triple phase CT with appropriate phases is very important to really assess the response. If you do dotatate or octreotide scans for neuroendocrine patients, a follow-up dotatate scan may be a reasonable strategy as well. And I think it's important to really rely and assess response on long-term post-procedural follow-up, somewhere at greater than 3 to 6 months, or probably out to 8 to 12 months. This is just a plug for contrast-enhanced EUS, which is a very nice adjunct technology to use if you are doing a surveillance EUS on patients, because it really is a way to essentially identify the non-necrotic areas of the tumor, which are still showing contrast uptake during the procedure. You can see here, this is on the left is a tumor pre-ablation with a significant contrast enhancement that is subsequently disappears on post-ablation. And on the bottom, you can see that on B-mode ultrasound, it's sometimes a little bit hard to determine where to target the ablation area. But using contrast, you can actually use this to identify the areas where you may be able to stick directly the RFA needle. So what are some of the anatomical considerations that one should consider before selecting a patient for EUS-guided RFA? So I think the majority of these studies have typically used and included tumors that are somewhere in the 1 to 3 centimeter range. As you remember from the little graph that shows the ablation zone in relationship to the needle size, it really under 1 centimeter, much under 1 centimeter, it's a little bit hard to be sure that a significant ablation outside of the tumor is not accomplished. And over 3 centimeters will certainly require multiple ablation attempts. For tumor types, so I think there is an answer to how to deal with cystic lesions, but I think in general it is probably more favorable or at this point a little bit easier to justify solid lesions than cystic lesions, and I think we will see a lot more data coming out on ablation of cystic lesions. Proximity of vessels, so it is recommended that there is at least some distance between the larger blood vessels and the tumors you're ablating. There's both a safety concern and also a heat sink concern. In other words, the blood vessels essentially cool the effect of the ablation and may decrease the efficacy of the radiofrequency ablation. And similarly, a proximity of the pancreatic duct is something that should be considered, although there are really no reported significant leaks in the literature or pancreatic duct injuries. If possible, at least a 1 to 3 millimeter distance on EUS from the tumor to the pancreatic duct is considered, and some have advocated for the use of prophylactic pancreatic duct stenting in cases where the lesion is clearly closer to the pancreatic duct. So I'm going to show you a case that we have actually recently published in GIE. So this is actually something that if you want to sort of watch another video, I think hopefully will be available relatively soon. But this was a case of a 66-year-old woman who underwent who was diagnosed with a insulinoma based on biochemical characteristics. The lesion was identified on a CT scan to be a roughly 2 by 1 centimeter, 1.8 by 1.3 centimeter tumor. And she was morbidly obese with a number of comorbidities, and ultimately surgery was preferred not to be performed. This is a contrast CT scan showing the hyperenhancing lesion, and this is the endoscopic ultrasound. So this is the lesion. It's a nice bilobed lesion in the head of the pancreas. Actually, in this case, we did not have a histologic diagnosis. There was enough biochemical and imaging evidence that we combined the FNA procedure with the planned ablation. So at first, we're essentially measuring the lesion. And as you will see, we ultimately really felt we had to divide this into almost 2 tumors or 2 lobes. And so we used those measurements in determining the needle size that we use. This is just the fine needle biopsy of the tumor, and an on-site pathology was performed just to confirm adequacy of the specimen obtained. Again, there was sufficient preoperative suspicion that this is a functioning neuroendocrine tumor. And then we decided to proceed with radiofrequency ablation. We chose based on the tumor size. We chose a 7 millimeter needle, and in a moment, so this was chosen again based on this essentially diagram where the tumor size sort of determined the size of the ablated needle. Again, this shows the generator. The patient is grounded, and it's a very simple plug-in into this dedicated generator, which again will show the automatic sort of setup of the wattage used for the case based on the needle chosen. but it will also allow us to show, it will also show us during the procedure ablation time and impedance increasing during the procedure. So this is the actual ablation procedure being performed. And what you can see here is this is when the ablation begins. You begin to see this nice sort of white color change or echogenicity change, which I use at least at this stage to guide me essentially when the area of the tumor is sufficiently ablated. So I watch both the generator and the impedance value, the time that the ablation is preset for, but I also have the ability during the ablation to essentially watch it as it happens and use this essentially change as a way to guide sort of when I think ablation should be terminated. In this case, this won't happen, but if this area of ablation really were much wider than the tumor range, I think that would be sufficient concern to stop the ablation early. So again, this is a nice sort of built-in sort of safety feature of this technology. So here we're showing the ablation of the second lobe of this tumor. And in particular, since we're here close to the duodenal wall, I look for these marks to sort of extend to the duodenum, which they did not, and it would be something that would lead to stopping it. This is just a brief view of sort of looking at the site of puncture or the mucosa, and there really isn't any damage or mucosal injury that's seen, just a little bit of heme that probably is normal after the biopsies and the ablation. So insulinomas are probably the most rewarding type of tumors to treat with this technology. This lady did incredibly well after the procedure with no symptoms, and this is probably one of those graphs that I think really make you very happy for an intervention that you performed. This is her preoperative blood glucose levels in the setting of taking diazoxide to prevent hypoglycemia. This is when the RFA occurred, and she actually had underlying diabetes, and essentially within hours, if not less, but certainly overnight during her hospital stay, she developed hyperglycemia and eventually needed to go back on anti-hyperglycemics, and her hypoglycemic symptoms have completely resolved, and she's now over 12 months out from follow-up and continues to do well. So in closing, I'm just going to touch on the last few slides on slightly different avenues to deliver EUS-guided therapy, and this is cytotoxic directly delivered agents and strategies to enhance the immunogenicity of pancreatic cancer. I think directly injecting chemotherapy is one of those things that perhaps many of us have thought of for many years, and it's impressive that actually one of the first data about this really just recently came out. But nonetheless, this is still very early days. It's only a very small number of patients that were enrolled, somewhere less than 30, I believe, 35. And this is a study done by Michael Levy's group at the Mayo Clinic. But what is impressive to show is that there was potentially some clinical response, and they have actually nicely documented that when they were able to infuse the gemcitabine kind of throughout the tumor, those were the patients that had, to some extent, the greatest survival. So I think this is, at least as a proof of principle of injecting chemotherapeutic agents, is not a bad study to keep in mind. There were very, very small number of grade 1 and 2 adverse events described in this study. In cysts, there have been a lot more data that have emerged in cytotoxic agents, and I think this is good to keep in mind. It's a little bit hard to do in the United States, at least in terms of receiving approval and whatnot for injecting cytotoxic agents in pancreatic cysts. But I think what is the takeaway message from some of these studies is that increasingly the field has moved away from ablating cysts with alcohol and ablating them initially with alcohol combined with a cytotoxic agent, and then more recently in one actually a randomized controlled study using an alcohol-free arm. And what is notable about it is that the response rates are better than they were with the alcohol-only study originally, although in here they did see an alcohol arm up in the 70% range. Again, these are studies that are combining alcohol and a cytotoxic agent. So compared to the alcohol alone arm, there's significantly greater ablation response. But most notably are the difference in complications. So at least in the small number of patients who were in the alcohol-free arms, there were no complications, whereas in the alcohol arm, there were similar rate of complications as seen in the previous studies. So I think one area to watch is really the cytotoxic agent Taxols or gemcitabines injected in pancreatic cysts that may have sufficient efficacy with a much better safety profile than alcohol ablation. And then finally, I think an area of great interest will be the use of oncolytic viruses, essentially injecting viruses that directly infect and rupture and target cancer cells. And they can be engineered not only to rupture the cancer cells and thereby expose tumor antigens potentially, but also to deliver and express chemokines or cytokines that can further enhance the immune response that they draw. We participated or are still participating in a study that uses one of these oncolytic viruses. This is a herpes virus that is being injected, and essentially it's based on incredible responses seen in melanoma patients, which is why that picture on the left is shown. And then on the right, you can see one of our cases where the vaccine is injected in a initially 2 by 2 centimeter large tumor that shows a significant response. This is essentially the similar from a technical standpoint. It is an identical procedure to alcohol injection, or to a large extent, essentially an FNA, with some attention paid to potentially injecting multiple areas of the tumor and avoiding injecting near the blood vessels or in hypervascular areas. But nonetheless, this is still a very early phase study, and we have seen a bit of responses, and so far not a very significant toxicity. So to summarize, EUS is the safest way to deliver local therapy in pancreatic neoplasms. Both injectional and ablative therapies may emerge as an important component of therapy for premalignant cysts, typically mucinous cysts, neuroendocrine tumors, and pancreatic cancer. Targeted injectional therapies may offer a unique opportunity to increase the efficacy of anti-tumor immune responses, and this may also be true for some of the other ablative technologies. I actually didn't get a chance to touch on this, but there is some early data that there is a similar sort of increase in effector immune response in the post-EUS RFA treatment scenario. And then focusing on EUS RFA, this is emerging as one of the safest and most effective ablative strategies for pancreatic tumors. Most data is available for functioning and non-functioning neuroendocrine tumors that are somewhere between 2 and 3 centimeter size. There is reasonably good safety data and very good efficacy data for these tumors. It may be a possible adjunct therapy in locally advanced pancreatic cancer and in non-surgical candidates, potentially at a later date combined with immunotherapy and chemotherapy. There's generally good safety data here as well. I think the solid tumor ablation data from neuroendocrine and endocarcinomas can be combined, and that safety data is quite good for this technology. There's limited efficacy, and this is probably where we will see the greatest sort of clinical trial activity to further sort of understand the role of this technology in treatment. At this point, it's probably a rescue strategy for pancreatic cancer. And it may be effective in cystic neoplasms, and this is obviously an area that will that may see the greatest numbers in terms of use of this technology. But I think the important thing here is that because of the low risk type of lesions, and because, again, as I said at the beginning, really the focus here is on a very safe and effective technology, but the emphasis is on safety. I think we will need to see a little bit more safety data before this becomes a standard. But I think there's emerging literature that radiofrequency ablation of cystic lesions may be also feasible and effective. So I think I will stop and thank you all for your attention here from New York. And if there are any questions, I think we will move to the question part of the webinar.
Yes, so thank you, Dr. Gonda, for your insightful and detailed lecture on EUS guided therapies. So we will now move to the question section, and there has been pre-registration questions that we have received. And now the first question is, what complications are encountered and with what frequency?
Right. So I think the most feared complication that we always think about is clearly pancreatitis. For radiofrequency ablation, the cases reported have been, I think almost all cases have been mild pancreatitis. There have been some reports that have shown some peripancreatic inflammation, peripancreatic fluid, especially in the cancer ablation paper. They have reported that, although all of those, I think they reported 4 out of 11 or 12 cases, all of those were asymptomatic and just noted on imaging. And then, as I mentioned, there were 2 or 3 cases reported of necrosis and potentially infected necroses in the pancreas. And those were all reported in the cystic lesions. So that I think is an area a little bit of concern, and where one possible answer may be to making sure that that the cyst fluid is completely ablated, and perhaps that shrinkage in the size also guides the ablation time zone and energy used, which is then reduced and therefore perhaps leads to less necrosis.
Okay, thank you. Our next question is, what are the contraindications? Are there any issues with ablation near the main PD, CBD, or ampulla?
So I think I'm not sure if there are absolute contraindications. I think a lesion that potentially directly obstructs the pancreatic duct, or perhaps less so if it directly obstructs. If it's directly adjacent to the pancreatic duct, it is something where I think pancreatic duct stenting should at least be brought up. I did not see, and certainly have not experienced bile duct injury with EUS guided RFA. There have been reports of EUS guided alcohol ablation resulting in bile duct injury or cholangitis. Again, I think you want at least a 1 to 2 millimeter cushion. But again, the nice thing about this is that during the ablation procedure, you have the ability to visualize the kind of presumed ablation field. So you have the opportunity to terminate the ablation sooner, reposition the needle and whatever, if there is a concern.
Next question is, can it be used for IPMN?
Right. So I think it can be used for IPMN. It's just a question of how, in what setting you use it for IPMN. And one is sort of the clinical question, what risk patients you're dealing with, and again, 2, there's a little bit of a safety concern from some of those papers, which I think will be hopefully dealt with.
Mm-hmm. Our next question is, have you already, or do you envision using RFA in non-surgical patients with adenocarcinoma of the pancreas and not just NETs?
So I think in personal experience I have. I think those are select patients. I think sometimes you encounter patients who have relatively few metastatic sites, or maybe even non-metastatic unresectable disease, and have not responded to systemic chemotherapy, and it is, I think, at least at this point, this is an option. I think the data is not broad enough to really tell us whether it's effective, whether what its true efficacy is. But I think it has shown reasonable safety profile, and I think it's a reasonable thing to consider in patients who have no good alternative, either systemic or surgical options.
Mm-hmm. Another question just came up. Your experience with ELRA, with USRA, is probably what he meant.
So my experience has been that it's a very it's a technically relatively easy procedure to perform. You need to have sort of good understanding of the anatomy, and and certainly certain endoscopic positions are easier to perform ablation than in others. Having said that, I have not encountered, in particular, like the head of the pancreas in the duodenal position, is always challenging for 19 gauge needles. I have not found that it is not possible to do the ablation there, but it is a little bit technically more challenging. I think good sort of it's very important that especially since this is early days, that you do this in good collaboration and consensus with both surgical and oncological colleagues, whether it's neuroendocrine tumors or adenocarcinoma. But I think overall, for those of us who are experienced at doing endoscopic ultrasound, fine needle aspirations, biopsies, I've done celiac nerve blocks or whatever, the technical parts of this procedure are not difficult to learn.
Thank you. And then the next question is, how long is the survival rate of the EUS RFA for pancreatic cancer?
I don't think we know the answer to that. And again, I think the part of this that's so difficult is, it will depend heavily on what is the combined systemic therapy that is given. I think the probably the first question we will get the answer to is what is the sort of the response rate after treatment, at least in terms of imaging, demonstrating necrosis and changes. I don't think we will really know a specific EUS RFA specific survival rate until a true clinical trial is conducted.
Yeah, we have a couple more questions. Our next question is, how did you approach the cost and approval of RFA with the institution by Dr. Willingham?
The cost of approval. So that is a tough question, and I think it depends very much on your institution. I think that you can, especially for the neuroendocrine tumors. I mean, I think one of the ways you can approach a cost benefit of this technology is to compare the potential cost of a surveillance strategy, a surgical intervention, and an outpatient procedure. There is a cost in obtaining the generator, which your institution will have to kind of approve. Afterwards, the cost of the actual disposable components of the procedure are relatively modest. So I think if you can demonstrate that this is something that potentially can compare or can be compared to a cost of a surgical procedure, I think that's one of the ways that we can go about it.
Mm-hmm. And next question is, what's your follow-up protocol?
So so my follow-up protocol, and again, this is a relatively new technology, so I certainly don't have years of follow-up experience with it. But my follow-up protocol is evolving, but is increasingly, to not act on a CT scan or which would be the frontline sort of follow-up, a triple phase CT scan, not to act on partial responses seen on a CAT scan at, let's say, 2 or 3 months post-procedure. Now, most patients will want to have a surveillance scan, in my experience, at around that interval. I think if I have a choice and if I can make a recommendation, I probably would say that for small neuroendocrine tumors, stick to the otherwise recommended surveillance interval of 6 to 12 months, and I think you will more likely to be able to define or find complete responses at that point than if you look much sooner than the procedure. Now, if the lesions are greater than 2 or 3 centimeters, and I fully expect that that I will need to do multiple ablations, or at least I think that there's a great chance of that, then I think I will do an endoscopic ultrasound as potentially a surveillance procedure. And if you have the ability to use contrast, I think that is a good time to include contrast-enhanced EUS as a way to survey these lesions.
Thank you. So 2 more questions. How many applications per sessions, and do you need to repeat in the future?
Yeah, so I don't think that there is a standard of care answer to that. I think, again, it's size dependent. Some of the literature shows that in 1 to 2 centimeter lesions, one ablation is effective in over 70–80% of the cases. I think if the lesion is in that range, I would perform the ablation, and I would go to a cross-sectional imaging afterwards to survey. And if there is no lesion found on that, then I would assume that this was a complete response. The patient may continue to go on with surveillance. That's a different conversation, but I would not perform any more procedures. In lesions that are greater than 2 or 3 centimeters, and probably in cases of pancreatic adenocarcinoma, I think at this point I would be prepared to perform more than one ablation, so either 2 or 3 ablations, and that's what I would tell the patients to expect.
Thank you. And then for our last question is, any issues getting to the head of the pancreas? How do you know how long each ablation should take?
So there's definitely a little bit more challenge with certain positions in the head of the pancreas or in transduodenal approaches. Again, the material of the needle actually helps you a little bit because it's you're using the needle typically once or twice, but I have not had a case where we were not able to perform an ablation in the head of the pancreas. Nonetheless, I think if there is a patient with an uncinate lesion, I would always counsel them that there is a possibility that it will not be possible to perform an ablation. And then the other question was how long to perform the ablation. So again, it is somewhat predetermined based on the setting and the wattage that is delivered, but it is not fixed. So it is at the end, in your hands, so to say, how long you perform the ablation. And I use a combination of the preset numbers, the change in impedance during the procedure, and the endoscopic ultrasound changes those white sort of bubbling changes that we saw on the video to guide when I terminate the ablation.
Okay. Thank you, Dr. Gonda. It seems we have reached our time and we'll end the webinar. Thank you for your lecture, and this has been a truly wonderful experience. We truly hope this new exciting technology can help patients with a safer alternative. And we thank everyone that attended today, so please keep a lookout on future events, and we will be in contact with those who requested more information. We appreciate your service in the healthcare field during these times, and stay safe, and thank you very much.
Thank you all. Have a good evening or afternoon.
Thank you.